This graphic outlines the 4 core pillars of prescription safety. A physician's prescription is essentially a clinical hypothesis. Before that medication reaches a patient, it must pass through a final, structured test, the pharmacist's appropriateness review. Let's examine frequency errors. This graphic shows a severe error, methotrexate prescribed QD, or daily. For rheumatoid arthritis, it must be dosed strictly once a week. We verify clinical intent by checking other meds. The bottom text shows weekly folic acid, given to reduce toxicity. A single clerical slip, typing D instead of WK, turns a standard treatment into a fatal poison. A systematic review process catches these precise points of failure. Evaluating the right drug means actively looking for therapeutic duplication. As this model demonstrates, prescribing 2 drugs from the exact same class offers 0 additional benefit to the patient, but strictly multiplies the adverse side effects. This chart shows a real-world example. Patient D has active prescriptions for both dexlansoprazole and pantoprazole. The panel identifies both of these as proton pump inhibitors. A prescriber must be contacted to stop one of them. Overlaps aren't always exact duplicates. We screen for hidden structural clashes, like allergy cross-reactivity. This diagram shows a severe amoxicillin rash. An incoming order for cefixime triggers an immediate warning. Despite different names, penicillins and cephalosporins share a chemical family, putting the patient at risk. Verifying the correct drug requires looking past the brand label and understanding the underlying chemical structures. Even when you have the correct drug, a mathematically standard dose can still be clinically wrong. Patient variables like age, weight, and kidney function dictate necessary adjustments. This graphic illustrates a pediatric dosing error, an adult Montelukast dose given to an 8-year-old. Now consider a complex algorithm. A 78-year-old, 54 kilograms, with 1.8 creatinine is prescribed apixaban. Evaluate against the criteria. She fails the age check, but meets the weight and creatinine thresholds. Because she triggered exactly 2 of the 3 criteria, her dose must be reduced to 2.5 milligrams. Algorithms serve as holistic checklists, not single variable lookups. Standard prescribing rules invert completely when dealing with special physiological populations, specifically pregnant patients. Looking at this diagram, we see ciprofloxacin is strictly avoided due to the risk of fetal cartilage damage. Conversely, enoxaparin is the safe intervention of choice for blood clots because its molecular size prevents it from crossing the placenta. Moving past the patient's internal physiology, you must screen for external interactions. This means identifying dietary blockers alongside drug-to-drug clashes. This chart highlights a key dietary interaction. A high-protein diet directly blocks the absorption of levodopa in Parkinson's patients. Resolving this doesn't require a medication change, but it does mandate strict counseling on meal timing. Clinical appropriateness extends into the patient's daily life and diet. You have to understand how the medication behaves in their specific environment. The ultimate test for a pharmacist is a prescription where the math is perfect, but the clinical premise is invalid. We must always question the core indication. This illustrates wrong indication perfectly. Prescribing reserve antibiotics like linezolid for a viral sore throat is clinically invalid. Also, beware overtreatment. A patient dropping to 5.7% HbA1c and experiencing fainting shows active hypoglycemia, requiring an immediate modification of their regimen. Evaluates 8 strict points: verifying the right drug, dose, frequency, patient, and indication, while actively screening for duplications, interactions, and contraindications. By systematically applying this checklist to every single order, you ensure that clinical theory translates into actual patient safety.